we were watching the horrifying scenes of hospitals flooding with severe cases of coronavirus in Italy and other countries. It was a big moment for the whole world, and obviously for those of us working in public health. The main aim was to minimize deaths from this awful virus, to protect those at high risk of death, the vulnerable. We had an idea of who the vulnerable might be, older age groups, those with underlying medical conditions. The rest of us will be fine. The world was reassured. Our main job is to protect the vulnerable. This message was conveyed with such certainty at the time that I found a bit puzzling. How do we know that this new virus, this virus that we knew very little about, would have no long-term health consequences on some of those infected? Because we knew that there are several other viruses where an infection can result in a chronic illness. Post-viral infection or post-viral disease was not a new condition, but it was totally absent from public messaging at the time. There's nobody in the news or media talking about this potential outcome of the pandemic, which is chronic illness and disability. On social media, on the other hand, there's another story emerging. People who were getting infected with COVID were saying, it's strange, they're not really recovering quickly, maybe for weeks or even months. The symptoms keep coming back to them. Many of them were people of younger age groups, people with no underlying medical conditions, so not those who are classed as vulnerable. And this, these stories on social media of the so-called mild COVID-19 infection was emerging. People basically were experiencing symptoms like extreme exhaustion, muscle pain, joint pain, chest pain, palpitations, dizziness. Some of them couldn't really do their simple basic task, daily task. Some of them couldn't get back to work. Some tried to get back to work and were struggling. Some had new memory and concentration problems. Some of them continued to work throughout the acute mild illness at the start, thinking this is going to be a really short flu-like illness, like I did, only to crash after a while, like I did as well. For me personally, this weird experience of not recovering from the virus, of getting these symptoms again and again, every time I thought I was on the mend, they were coming back. It was horrifying. But actually, social media made it more tolerable for me. It was the only source that you could see the accounts of other people experiencing the same, where you could actually see that it wasn't only me. There are other people experiencing this. There were lots of stories out there from all over the world, not just one place, of similar stories, certainly enough stories for the politicians, the experts, and the doctors to pay attention to this. Actually, some of these stories came from doctors and other health professionals experiencing what we now know as long COVID. Healthcare workers were among the professional groups who had some of the highest burdens of these conditions at time during the pandemic. So I decided to share my experience as well, particularly in terms of what it means in public health terms, because I saw a gap there. So I wrote about it in July 2020 in the British Medical Journal. I shared my story with hesitation and with nervousness, but I was actually describing my lived reality and the reality that was consuming the lives of many other people, except it wasn't really talked about through official channels and wasn't counted or quantified. I said at the end of that piece in the BMJ, death is not the only thing to count in this pandemic. We must count lives changed. We know very little about COVID-19, but we do know that we cannot fight what we do not measure. My piece got translated into many languages and shared widely. There was a clear gap in the awareness and knowledge around the long effect of COVID. My message as a public health doctor was this: count long COVID. Don't just count the number of deaths, the number of infections, the number of hospital admissions. Count the chronic illness and disability generated by this virus. Because I knew that if we don't count something, we don't account for it in policies that shape people's lives. All of this, the narratives that we kept hearing since 2020 about, public health versus the economy, to me, was represented a false dichotomy, because if you protected public health, you're likely protecting the economy too, particularly if you count the effect of chronic illness, because the economy needs a healthy workforce. So when I shared my story, I was worried about saying something different, calling for something different. I was also concerned about mixing my personal story with my professional thoughts. I remember once I was invited to speak at a scientific event about long COVID, and then asked whether I was going to speak with my professional hat on or with my lived experience hat on. So basically, shall we introduce you as a doctor or as a patient? It seemed inconceivable to some that I was there as both, which is basically my whole self. Because after all, this thought of objectivity is a core notion that's drilled into us, really, in our professional training. So if you have a health condition and you're also working on it, talking about it, researching it, you can be perceived as biased, as being biased by it. But actually, I thought, at the time, I realized that that's not necessarily true. Not having that experience, not knowing what it's like, does not make you objective by default. You can also be subjective, and you can be open to bias. If you don't know what it's like, you can miss really crucial perspectives to some patients. You can dismiss or contradict certain aspects of the patient journey. That's why it's widely accepted now that patient involvement is central to shaping health research and healthcare pathways. Because in truth, no one is entirely objective. We're all humans. What we can do is be transparent about what shapes our views. The healthcare workers and health researchers who experienced long COVID sat on that other side of the table, where the patient is, and experienced what it's like to have that condition, and that enriched their perspective. So I ask you to reflect on this. Why is lived experience automatically considered to compromise rigor in science? In fact, there is power in knowing, understanding the specific vulnerabilities of a certain condition, because that can help you ask the right questions and try and find the relevant solutions and answers to support others. Now, talking about power, most people with long COVID were not in positions of power, not in their individual clinical consultations where their symptoms were commonly dismissed as stress or anxiety due to the pandemic or lockdown, and not in a workforce that they're trying to get back to and fit in with, but that workforce is really keen to get back to normal and perhaps not adapting flexibly enough to the needs of a potentially less healthy workforce. And not in a society overall which really just wanted to forget about COVID and all its devastating effects, understandably. So that's why many felt they had to share their story. And they had the same message. They wanted to warn others about the virus, that COVID is not necessarily harmless in the young and healthy. It can change your life. We actually do not know who the vulnerable are. So patients formed peer support groups. Patient advocates got together and learned how to interact with the media and with policymakers. Patients started designing and conducting their own research to describe their condition despite their own illnesses. In fact, the actual name long COVID is a patient-made term on social media, and that remains the commonly used descriptor of this condition, despite many other technical terms emerging. We kept repeating the message, saying it over and over again, persevering, count long COVID, until some of those in positions of power heard the message, and long COVID was acknowledged, clinics started to get established, research started to get funded, and attempts to count it started as well. But there's just still so much to do. There's so much we still don't know about it, so many questions to answer, including how to treat it. Also, there are needs, there are questions and there are issues about prevention. In terms, for example, raising awareness about well-ventilated spaces. And the attention is needed not only about long COVID, but about this wider group of illnesses, understudied group of chronic infection after viral illness. So long COVID is not something that only happened in the past. It's still happening. So the fight to highlight its importance and effects on people's lives and livelihoods continues. There is a quote by one of my favorite authors, Khalil Gibran, and it goes like this: "I learned silence from the talkative, toleration from the intolerant, and kindness from the unkind. Yet strange, I am ungrateful to these teachers." Long COVID has been my teacher, a teacher to me that I'm ungrateful to. However, I am grateful and thankful to all the people along the way who made the lessons bearable. And long COVID showed me the power of peer support, solidarity, listening, and supporting each other. When the world doesn't want to hear your story, the people who actually identify with it, who live it, become your source of strength and help you cope with all the uncertainty. Long COVID also empowered me to question the dominant narrative, and that's not only about the pandemic, but also about unspoken rules within my own profession. Somehow, it pushed me down so much that it freed me to look up and gave me courage to differ when my reality didn't fit in the mainstream narrative. Sometimes you're bravest and you're most likely to make a difference when you're at the height of vulnerability. Thank you.